Everybody, welcome again to the National Orthopaedic Alliance webinar series. I think we're on number 16 now. It's July, I think, since we talked last, and lots of things have happened over the summertime. And so today we're very lucky to have two eminent speakers. We've got a patient, Val Harvey, who we know very well because we've watched her her problems and her wait for surgery over the last couple of years. We first met Val, I think, in around May 2020. So she's got a story to tell us. And then we're lucky to have Paul Jenkins from Scotland, who's going to give us an overview of what's happening north of the border, especially in relation to the orthopedic recovery and what's ahead of us. So, sorry about this now. Page down. I beg your pardon. I'm just getting a little bit confused. Now, just to say, this webinar is being recorded. It's available to members tomorrow. We've got all participants are on mute. There is the question tab, so please put any questions on the question tab. And use the chat if you have any issues and you want to message the coordinator. Just a little news update. So we're all back from our holidays, hopefully, and most of us had it as staycations. There's been a bit of an issue with that because we know that there's been a peak in Devon, Cornwall area. The pandemic has affected us all and also affected our surgery in that many of our staff have been pinged. And the need to isolate after that has affected staffing. We're hearing about supply chain issues in construction, but also in the NHS. And you know, a shortage of blood bottles. This has affected some research projects. It's also affected some COVID. It's some COVID research, I believe. So they postponed some antibody tests because of that. It's very rare that the COVID thing comes off the screen, but the Kabul evacuation gave us some temporary relief from the COVID headlines, but that didn't last long, and we're back on board with our daily headline news around COVID recovery, the NHS, etc. We hear there's about 5 million people now on elective waiting lists in the UK, a huge, massive challenge because we're seeing our infection rates go up, our hospitalization go up, but great protection from the vaccination program and a great eagerness to try and get more people vaccinated. And as you probably heard, younger people as well. Kids going back to school, we expect the worst because they're going to be mixing. So uncertain times ahead. We've heard about our health and social care tax. So that's going on national insurance, billions of pounds involved here. It'll go into effect in a couple of years, but the first monies is going to go to the NHS to help in recovery in the first instance. So that should be good news for us all, and also good news for orthopedic elective recovery. Vaccination rollout for 12 to 15-year-olds is going ahead across all countries. I think at different timelines. But the general feeling is that it'll be offered to 12 to 15-year-old, not mandated. And there is differing opinion on the usefulness of that, but dialing in education disruption, the feeling is certainly in NHS England, PHE England, that it is a useful thing to do. I'm over 50, so I'm lined up for my booster. I'm also vulnerable because I'm on steroids, so I should be getting a booster jab. And that's going to roll out again towards the end of the month, we understand. The infection rates are variable across England and Wales. They're about 65 per 100,000 England and Wales, a little bit less in Northern Ireland, but higher in Scotland. We'll probably hear more about that from Paul later on. Some sad stories over the last few months. I think the most tragic one really was the husband of a young mum who unfortunately died of COVID, unvaccinated, and his appeal to pregnant women to get vaccinated. Then we had Boris on the TV talking about jabs for jobs. And also the NHS Plan A and Plan B. Plan A is basically to jab our way out of this crisis, to protect the NHS, continue with contact tracing and self-isolation. And Plan B is the thing that we don't want to hear about, which is going a little bit backwards. Passports, mandatory masks, working from home, but nothing has been excluded by the government in terms of what might happen if the pressure increases on the NHS. Just a little update from our local hospital. We're pretty green and clean. We're continuing to do elective surgery. On the grapevine we hear, I think the dedicated elective surgery orthopedic units seem to be doing better than others. There's still encroachment on beds and time and theatres in hospitals, which are sharing with other subspecialties, but the dedicated units seem to be doing a little bit better. We found intermittent disruption around staffing, COVID infection, isolation, our staff picking it up from their kids and having to go off for 10 days, cancellation of clinics and some theatre sessions as well. And we are doing reasonably okay. Our plan was to try to get 100% activity. In some areas we've met this, but we're about 75% of 2019-2020 activity. So not enough to play catch up at the moment. We have been offering waiting list initiatives and there is some take up of that, but there's mixed and less enthusiasm for various reasons around taking up waiting list initiatives. I think most notably, some of our surgeons are absolutely jaded. They've had enough and they want to spend Saturday with their family rather than doing extra lists. So that's been a tricky one. So even though the money is there, I'm not so sure the enthusiasm is there. How we get through that, I'm not sure. We've had a minor hospital outbreak. It's hard to call it a hospital outbreak because it really happened in a restaurant, in a local restaurant where some staff members just socialized in a local restaurant and 3 of them tested positive, but it did take, I think, 10 people out of the trust for 10 days. We are, like some other hospitals, we're planning a joint fest, so we're planning to try and get back on board with joint replacements, an intensive 6-day elective joint replacement surgery, hopefully opening as many theatres as possible. A very big push on joint replacement, and this is planned over the next month or so. So hopefully, if that's successful, we'll be able to resource further initiatives like this. And I see that other units are trying to do something similar. And these are some of our numbers here. On the right is some of the graphs. It just shows you that what we planned and what we hope to do compared to the 2019-2020 numbers is slightly out of sync. We're not quite getting there, and that's really around staffing issues and being able to go full whack at it. Beds is increasingly becoming a problem as well. So it's a combination of issues that is influencing this recovery for us. But I think we're probably doing well. Certainly compared to other hospitals, I think we're happy the way things are going. Love to do better. Once again, I listen into the British Orthopaedic Directors Society chat, very useful, seeing what's happening around the country. And these are some of the themes that we've picked up over the last few months. A lot of our sons and daughters gone to the various festivals, and that's been good, but some of them have brought COVID back with them. And unfortunately, that's influenced our ability to work because we've had to isolate. So that seems to be a general feeling across the country at the various festivals. I think it's a big hit down south, especially in Devon and Cornwall. There has been a PHE update on the rules of isolation, especially for certain companies, about the ability to return to work if you had been contacted by test and trace, which mandates that you basically you leave work, get your PCR tested, but if your PCR test is negative, then you can return to work providing you're willing to and you have daily lateral flow tests. That applies to the NHS, but one of the caveats it excludes, in England anyway, it excludes close family contacts. So that's a problem. So close family contacts, you do have to isolate still with the 10-day rule. However, there seems to be some variance in the interpretation of this, because there is a caveat that there is a local decision-making process. And I understand the rules are quite different in Scotland, where the actual procedure does include close contacts, so that you can actually return to work with a negative PCR and daily testing. There's issues around consultants returning to normal practice after shielding. Some of them are, some of them are not. It's a tricky one. Staffing is an issue, covering for consultants that are not there, consultant cover for trauma lists. That's been popping up on a regular basis, and also career progression linked to that, career progression for non-consultant grades. So some of our excellent staff grades who help us out have been asked to do extra work and to cover, which is appropriate in certain circumstances. But I know that we have a new 2021 specialist grade now approved by the BMA after negotiation. So that hopefully will help us out to make sure that our staff grade, specialist grade orthopedic surgeons are respected, paid well, and given the appropriate recognition for helping us out. Also pressure on beds. So some units having pressure to put on beds to mix wards, mix elective orthopedic with other subspecialties. That really goes against the BOA and BOS guidance, and in terms of infection prevention. So what we don't want to do is see an increase in both MRSA and other infections, cross-infection with other subspecialties. But there is pressure from managers, I believe, to try and mix wards, which at the moment, my understanding is still being resisted. So on to our webinar and our two guests. I'm delighted to see Val on board here, who's joined us now. We met Val, I think, back in May 2020. She was in big trouble then. She was waiting for a hip replacement. Sorry, she was waiting for a knee replacement. And she kindly talked to us about where she was at that stage. The worrying thing that we heard is that the shape of her knee was changing. And now, to a shoulder surgeon, that's bad. To any surgeon, the change in shape of a joint is not good, and sort of can imply bone loss and deformity and soft tissue compromise. So that worried us. So what I'll do is I'm going to go straight to Val and ask her to join us and give us a story. So Val, if you can share your screen, and let me just say, I'm delighted that you could join us today. And if you share your screen, we'd love to hear your story. Where are you up to? I know you've had some grief over the last few months. Thank you, Val.
Okay. Can you see me?
Yes, I can. Well done. Yes. Thank you.
Okay. Right, here I am again.
Third time.
Yes, yes. My background is from nursing. I worked mostly in the community. I was a district nurse for many years. My last job was an HIV clinical nurse specialist. I've also worked for the charity Arthritis Care, or Versus Arthritis as it is now. I feel as though I've been on a bit of a journey these last few years. And I think I'm actually very typical of many orthopedic patients at the moment. If I can have the first slide, please, Ian. Right, a little recap here. In 2018, I developed increasing pain in my left shoulder and knee. I was diagnosed with osteoarthritis in these joints, also my right knee and hip, and both wrists. I was feeling very unwell at the time, and I was diagnosed with polymyalgia and prescribed high-dose steroids. I'm also diagnosed with osteoporosis, and I'm on yearly zoledronic acid infusions. So that was me. My shoulder was the most painful and debilitating, so that was the joint I went for to have replaced first. I went through the process of physio and steroid injection, none of which helped really. And I eventually had a total shoulder replacement in August 2019. And this has actually been very successful. I'm very pleased with this operation. If I can have the second slide, please, Ian. Thank you. By the end of 2019, my left knee had become very painful and I had difficulty in walking. I was due to have a total knee replacement in March 2020, but my operation was cancelled the week before it was due, as COVID had stopped all elective orthopaedic surgery. 2020 was a terrible year for me. My knee joint deteriorated, and as Cormac was saying, you could actually see the bone deformity and the overgrowth of the bone. My right hip also became very painful. I could only walk a few steps, leaning heavily on my Zimmer frame. I couldn't get down my front steps, so I was confined to my flat. I could barely wash or dress myself. I couldn't do any sort of housework or cook or prepare a meal or anything like that. I was in severe pain and I was taking eight tablets of codidromol, 30 milligrams every day, just to keep the pain under control. If I can have the next slide, please, Ian. Thank you. I developed the complications of immobility. I had a urinary tract infection, which needed antibiotics. I had a sacral pressure sore, which needed the district nurses. I had anemia for some reason. I've never been anemic before. And I had numerous investigations for this. They never found a cause for it. Eventually, I had 2 iron infusions, and that cured it. My mental health suffered. I had no fresh air, no sunshine, no outdoor stimulation. I became very claustrophobic, and I actually had one panic attack where I felt I couldn't breathe at all. I think my daily meditation practice helped me to go through this. I also think that living with constant severe pain and taking continuous heavy-duty painkillers is no good for anyone's mental health either. Elective surgery eventually resumed, and I had my total knee replacement in October 2020. This has not been completely successful, and I'll go on to that in a minute. If I can have the next slide, please, Ian. By the end of 2020, my right hip had become very painful. My mobility was still very restricted, and I was still on heavy-duty codeine. I saw a hip surgeon in November, and I was put on the waiting list for a total hip replacement. The list was about 6 months, but by the end of December, all elective orthopaedic surgery was stopped again due to COVID. I couldn't face another year like the year I just had. Another year of pain, of immobility, of maybe being confined to my flat, watching the seasons change through the lounge window. I just couldn't face that again. So I had my operation done privately in February. This has been very successful, but there was some soul searching on my part. I actually felt very guilty about going privately. I felt disloyal to the NHS because this is something I'd always believed in. I'd worked in it for over 35 years. I also felt guilty that I was able to go privately. I was self-funding, so it made a huge hole in my savings, but I was able to do it. For a lot of people, this is not an option. And I know there's a lot of people still in pain and immobility, and still without a date for their operation. Somebody said to me, well, at least there's one extra space on the NHS waiting list now. I suppose so. The person behind me in the queue at least moved up a space. So that's one way of looking at it. If I can have the next slide, please, Ian. In June this year, the pain in my right knee was increasing, and I'd also developed pain in my left knee that was operated on. I've seen another orthopaedic surgeon, and apparently the pain in my left knee is from the patella. Apparently some surgeons routinely resurface the patella during knee replacement and some don't, and there isn't a standard practice across the department. Mine didn't, and it now needs resurfacing. To the surgeon, this is a minor operation, but to me, you know, it's another anaesthetic, another surgery, another stay in hospital, another recovery. I could have well done without it, but hey. I'm on the waiting list for a right total knee replacement. The original waiting list was 10 to 12 months, but they're working really hard to reduce the backlog. I gather they've been working on Saturdays. They've had 2 theatres going at the same time. They're really working very hard to reduce this. So I'm hoping that I can get this done within 6 to 7 months. And apparently, if that goes well, I can get my patella resurfaced about 3 months after that. So I think I'm approaching perhaps the end of this journey. Perhaps there's a light at the end of the tunnel for me, unless COVID steps in again, of course. Thank you.
That's great, Val. Thanks for that. It's a disturbing story, especially the need to feel that you needed to go privately. It's interesting because all joints are linked, and you know, there is, as a shoulder surgeon, hearing that you had a shoulder replacement and then you went off your legs and had problems with your knees and hips. I get very worried about people having joint replacements, lower limb joint replacement, going on crutches with my shoulder replacement in there. Was your shoulder replacement affected by the use of crutches?
No, actually it was all right, because there was, I mean, by the time I got my knee replacement, it was like 14 months after my shoulder.
You're well recovered. So
it had given it really good time to heal. I suppose that was one good thing that came out of that.
Yeah,
but
but
no,
you also describe how your general medical condition, your physical and your mental condition deteriorates during this waiting period.
Yes.
I was interested, you said that the thing that helped you was meditation. Were you into that beforehand, or were you advised to do that?
No, I'd have a daily meditation process anyway. I used to do yoga every morning as well, but I haven't been able to do that for a long time now. And it's actually one of my goals, to be able to get back to some sort of daily yoga practice, and perhaps even to get back to a yoga class.
Okay.
I managed to come off, I no longer take the heavy codidromol tablets. I'd have no pain at all in my hip now, so I was able to stop that. I was addicted to codeine. I had a physical addiction to it, and it took me about 4 weeks to wean myself off it. I don't think I had a psychological addiction. I didn't crave it, and in fact I was very glad to be off it, but I was addicted by the end of it.
And who helped you with coming off the codidromol? So that's something we underestimate, because many of our patients are on lots stronger stuff besides codidromol. They're on tramadol and all sorts of other drugs on a long-term basis just to control their pain. Did you get help coming off the codidromol, or was it just
I didn't.
mental toughness?
Yeah, I did it myself. I mean, I looked up and everything, and you know, I have I'd worked in the drugs field before.
Have you?
I thought,
And what did it feel like coming off it? What sort of symptoms did you get? Did you get withdrawal?
I did one day come off a bit too quickly, and I had diarrhea. I had the shakes, really shaking, and I felt generally quite, oh dear. And I thought, oh gosh, I've done this too quickly. So I went back up again for a little bit. It took me about 4 weeks altogether to come off. But
well, it's been great just hearing your story there, Val. We'll hang on to it because there may be some questions coming your way. And
yes.
Thank you for that. I'm just going to I go straight to Paul Jenkins. Welcome, Paul. Paul is involved in the BODS and British Orthopaedic Directors Society as well, and lots of other things north of the border. So I see his posts every now and again. But I want to thank you for joining us and just giving us an update on what's happening locally in the Glasgow area, but also in the wider area in Scotland. What's working, what's not working, and where you are with the orthopedic recovery. So thank you, Paul. Away you go. Thank you.
Thanks very much, Cormac. It's a great honour to be invited to come and to talk to the NOA and really present the COVID and orthopaedic situation in Scotland. I'm an orthopaedic consultant at Glasgow Royal Infirmary. Similar to Cormac, I specialise in the upper limb, shoulder and elbow, along with sort of general trauma. And for my sins, I also am the clinical director for orthopaedics at GRI at the moment. I also sort of sit as vice chair of SCOT, which is the Scottish Committee for Orthopaedics and Trauma, and it's a sort of organisation that brings together a lot of the orthopaedic community within Scotland. By way of how I've sort of structured this talk, I was going to give a bit of a sort of overview of the NHS in Scotland, followed by sort of just what's happened with COVID specifically in Scotland. It's very similar to England, but there are some nuances. And what the effect has been on both our inpatient and our outpatient workload, along with perhaps how it has driven some innovation and transformational change that we perhaps didn't foresee moving forward to, certainly at this point in time, and then really what the challenge is for the future. Scotland is, the NHS is divided up slightly differently. It's a slightly more traditional setup with territorial NHS boards which look after various regions, and there's 14 of those covering the areas within Scotland. And then there are a further 8 special boards which have got responsibility for things such as education, public health, etc. And they sort of sit separately, but they have the same legal status as a board. The Scottish Government has got devolved responsibility for healthcare within Scotland, and a lot of health policy is different in terms of funding and priorities and the other sort of issues. So we work within a different framework. In Scotland, we've recently had set up what's termed the Centre for Sustainable Delivery, and that's taking a lot of responsibility now for driving forward some of the transformational change that we're looking to establish as we recover from the issues of COVID. And also, just to add to everything, we have been a bit late to the game of instigating a trauma network, really emulating the English sort of trauma networks, with just the final 2 MTCs only coming live in this last month. So there's been a lot of reorganisation surrounding the trauma side as well. So that gives a bit of a background as to where we are. SCOT itself is a sort of loosely formed committee as an executive of a chair, a vice chair, treasurer and secretary, along with regional representatives from all around the country. And we meet twice a year, and we organise both sort of educational and sort of social meetings. But what has come to the fore over the last 2 years has been the links that we have with the Scottish Government and these other agencies such as the Centre for Sustainable Delivery, as we really have been able to have very high level contact and influence over policy making and decision making within the government. So I'd hoped when I was first invited for this talk that I would be able to talk, quite positively. We've been through a very challenging, difficult time, really the most we've seen for several generations, and we were going to be talking about remobilisation, recovery and redesign, how we were going to renew and refresh NHS Scotland. We had the good news story of the vaccinations with the numbers of 2 doses complete really sort of rising throughout all 4 devolved nations, getting to very, very sort of pleasing levels. But what we've sort of had over the summer, and it's very similar to what Cormac has said, is that we've had a combination of festivals. We've had return to school, which happened in Scotland around the middle of August, earlier than in England and Wales. And we've had a return to pubs and clubs. Quite interesting, we have retained a degree of mask mandates within indoor areas, public transport, etc., which I think is a sort of stronger level of advice than England, but that has remained. Unfortunately, that has transpired into a further peak that we have seen in Scotland, and only last week in Parliament, Nicola Sturgeon warned that the NHS was under very severe pressure. And we can sort of see this peak at the very right-hand side of the graph being the sort of positive PCR tests. And that sort of started to peak again from about middle of August. Thankfully, we seem to be just coming down on the other side of that now. And it's interesting because up until the 16th of August, we were going along with the lowest rate of positivity within all 4 nations. Then suddenly on the 16th of August, there was this takeoff and this exponential rise again within Scotland, and we steamed past all the other nations. The most up-to-date data from today actually again shows that this has plateaued and over the last week has started to fall, which is sort of pleasing. We saw it sort of emanating out from the central belt to the areas of sort of South Lanarkshire and Glasgow, and within 4 weeks the rates were high really throughout the mainland and even into the Western Isles. That's sort of emulated because although we have a large amount of land mass, we've got quite a small population relative to, say, England, but there are some slight early peaks starting to be seen potentially around the north of England and South Wales again, which is potentially of concern. When we look at the sort of patterns over the longer term, Scotland again is the dark blue line here, and we can see that we peaked in the summer peak around the 28th of June. This actually coincides exactly with when Scotland were knocked out of the Euro Championship. So I think all the celebrating and the socialising happened, and then we were knocked out and people just stayed home and they were a bit depressed for the next few weeks. Interestingly, England peaked about 2 weeks later, and that coincides with their turn in the finals, which ultimately, unfortunately, they didn't win either. So there are really strong indications of the links to these sort of strong social occasions and people getting together in large ways. And then what has happened on the 16th, really, school pupils have gone back to school, but besides school pupils, that then drives there's people returning to workplace after holidays and all sorts of other interactions that weren't happening over the summer. What is interesting though is that this is the rate of hospitalizations, and compared to where we were in January and even before to March, the number of hospitalizations is at least, it's not even going to half of where it was, and similarly for admissions to intensive care, and that is heartening. If you look at these on a sort of relative chart, we can see that again during the sort of summer peak we had peaks in infection, then hospitalization, and then this is the death rate, this is the red line, and they sort of followed each other pretty much at the same level. Whereas with vaccination, that is decoupled, whereas we have much higher levels of positivity, but the hospitalization rate is much lower and the death rate is almost barely above where it should be. So again, that's very reassuring. So how has this affected Scottish orthopaedics? Well, it's really had a sort of a terrible effect. The outpatient waiting list within Scotland has grown from 27,000 patients in January 2020 to 40,000 in January 21, and it has grown beyond that. And the percentage waiting over 3 months has grown from 31% to 40%. When we look at the actual activity that's been going on in outpatients, the top line is 100% of what we would expect. The next line down is 75%. So even during our recovery at the best of times since COVID started, we've barely been touching 75%. And again, over the summer, we have had this falling away towards even closer to the sort of 50% line. Now, I'll talk about that a bit later because it may well be that there have been some innovations and changes in outpatient practice that may be contributing to this, but on the whole, it has been difficult to remobilise. When we compare ourselves to other specialties, we are at the lower end of the specialty, away on the right, just alongside dentistry, ENT, cardiology. Part of this is we've lost physical space. Some of our clinic space has been taken. Emergency departments have expanded. Minor injuries have expanded. Social distancing rules within the health sector have been much slower to be reduced within Scotland. So we're just about going to 1 metre spacing, and that limits how many people we can have in a waiting room or through clinic. So that's definitely a limit. The number of patients waiting over 1 year. It peaked at 4,000 patients waiting over a year, and that was in March of this year. Again, thankfully that has started to fall then over the quarter after that to now just about 1,500, but it has shown signs that that's tailing off, and that improvement has become stuck, and that is a concern. Even more concerning is there's a small number who are waiting up to and beyond 18 months, and that's for a first outpatient appointment. Inpatient waiting lists have also significantly grown from 21,000 to 30,000, and it is now sort of higher. And the numbers waiting over 3 months have grown from 43% to 70%. When we look at the similar graph of activity, that has really had, we've had our first loss of activity during COVID initially, and then we see a slow recovery during the summer months, up to a sort of peak in about October last year, and then sort of challenged through winter, and then significantly challenged with the second peak in sort of January to March, with recovery again, probably the best recovery we've seen in May and June, hit again over the summer with staff absence, even a degree of holidays, issues like that. But now pretty much every territorial board within Scotland over the last 3 to 4 weeks has cancelled non-urgent elective activity once more, which is challenging us. The long waiters, so the number of patients waiting over 1 year for surgery, has reached a peak of 9,300 again in March, with a small reduction of about 25%, but again, that is stuck, and we have a growing number of patients who are waiting over 18 months, and a small number who are now at the 2-year mark, which is really concerning. In terms of recovery, we're sitting about halfway in terms of our sort of surgical and other sort of colleagues within the health service. It's interesting, we often talk about inpatients and outpatients separately, but we have to accept that there is a sort of dynamic relationship, and this is an interesting sort of analysis. Each of these circles represents one of our health boards, so that this is my own Greater Glasgow and Clyde, and the width of the circle is the actual size of the waiting list. Along the sort of horizontal axis is the change in outpatients since the start of the pandemic, and on the vertical axis is the change in inpatient waiting list. So we can see that these boards in the right, in this top quarter, their lists both for outpatients and inpatients have both increased. Some interesting things have happened, because some boards, their inpatients increased, but actually their outpatients decreased. So something interesting was happening there. There was 2 boards, Forth Valley and Dumfries and Galloway, where their inpatient list fell. They were able to keep doing inpatient work, but their outpatients have suffered. Nobody, unfortunately, has achieved, the holy grail of a decrease in both outpatient and inpatient lists. When faced with all these sort of challenges, we can either try and do more of the same, or we can also try and put in place areas of transformational change, and we have been trying to do both. When we look at sort of outpatients, the normal sort of pathway looks at coming from referral through vetting to the outpatient appointment to then the sort of discharge and return process. And there are areas through all of this, all of these pathways, for there to be attention and work done to try to make that sort of more efficient. When it comes to sort of outpatients, Scotland has been very focused on something called ACRT. Now, as acronyms go, it's not very catchy. It's active clinical referral triage. It's making sure that the right patient sees the right clinician for their problem at that right point in time. Basically, it's enhanced vetting or it's making sure that they, you know, when they come to an appointment, they have the information that they need to be able to have an informed discussion, so that instead of when a referral was made, a patient would then be sitting with no information for perhaps even several months until they then come to their appointment. At the point of referral, we send information, and we have that, so that that's available for sort of discussion then during the subsequent appointment. We can determine if that patient might be suitable for non-face-to-face modes of contact, such as virtual attend anywhere, or video clinics, or telephone clinics. They might be better going straight to diagnostics, perhaps, if maybe an imaging modality would be more useful, or perhaps they haven't had effective physiotherapy yet, and that might actually be a more fruitful route at that point in time. So with some boards that we highlighted have managed to reduce some of their demand in outpatients by up to 60%. By doing that, that then gives the time for the patients who actually need it most, and sort of you know, allows that focus. There's been variation across specialties, so highlighted as trauma and orthopedics. So these were the boards who improved their outpatient performance over COVID, and these are the ones who decreased it. We can see across all specialties and throughout Scotland that there's a lot of inexplicable variation, and you sort of ask people, you know, why that is, and you'll get 100 different sort of reasons, and very often people can't actually get to the root of why that is. The boards which generally have improved their position have had an openness and a willingness to explore new options, to try to implement things that maybe aren't 100% perfect, but they're certainly better than not seeing people at all, or building up sort of waiting lists. We also have to sort of consider the return patient sort of conundrum, and the BOA, along with some of the specialist societies, put out this statement which said patient-initiated follow-up should be the default, with only a booked appointment where this is unavoidable. This is really looking at sort of patient activation, and it's giving them the information that is, you know, required for them to be able to get in touch when they do actually have a problem. There's no point seeing patients repeatedly who are well and doing fine, and just to say, hi, that's great, you know, that's fantastic. And whereas then if somebody actually says, I have a problem, can I come back and see you? They then can't get into that clinic because you're so full seeing people who are well without a problem. So, you know, patient-initiated return and introducing that is also about trying to, again, sort of activate these pathways and look at the sort of dynamic relationship between new patients and return patients. On the sort of inpatient front, or the sort of surgical front, there's also been the adoption of more sort of day case type pathways, which has allowed us to transfer some workload to non-acute sites to try to support an acute site, a hot site, cold site split. This is just a sort of, you know, the press tends to pick up on this quite a lot. But these pathways have been, you know, hugely successful and popular with patients. You know, looking at discharge on the same day, or, you know, most the next day following joint replacement. There's also been quite sort of fruitful research within the sort of the time of COVID within sort of Scotland. The impact sort of research collaborative was run out of Edinburgh, but really has been a sort of UK national and then a global confederation of researchers producing really several high quality studies which have highlighted the outcomes of COVID in patients with hip fracture, of arthroplasty. It's helped to guide some of our remobilisation issues, and perhaps it helped to sort of soothe some of the concerns about restarting surgery in sort of times of COVID. My colleagues, along with Impact and in Edinburgh, have produced research which has been picked up by the national media, sort of coining this term about the patients who are in a state which would be classified as worse than death whilst waiting for hip and knee replacement, showing that both whilst waiting for knee replacement and hip replacement, a reduction in this number shows a significant reduction in quality of life. And that has again been picked up nationally in in the Times and other outlets. Even today on the BBC website, and it's very relevant to the conversation Val was talking about, coming off opioids, and some of my colleagues from Aberdeen have just published this today in BMJ Quality and Safety, and they've shown that the number of patients on weak opioids has sort of increased from 38% to 50% during their time on the waiting list, and strong opioids have also sort of increased, and again any opioid use has gone from 40% to 55%. So that has got significant issues, as we heard, in terms of side effects at the time and potentially being able to come off that later. We were engaged sort of early on with the sort of Scottish Government because there was a knee-jerk reaction to concerns about aerosol generating procedures, and we do know that COVID is transmitted by respiratory aerosols, but this then really stopped the use in most circumstances of things like saws, drills, inserting K-wires, really without any sort of evidence base on sort of transmission via aerosolized blood. As the sort of SCOT committee, we engaged with the National Clinical Cell within Scotland, and that was ultimately escalated to NERVTAG, which was one of the UK groups informing SAGE and the government, and we were able to get those restrictions removed from the Scottish and then the UK infection control guidance. During this time, we've been driven to much closer involvement and public and patient engagement, which we should have been doing beforehand, but we are now doing that in a much more formal and engaged way. So we've got very close links now with Versus Arthritis, and in terms of being involved with their sort of campaigns, and particularly the more recent one about arthritis being impossible to ignore. Trouble with orthopedic cases being sort of prioritised really at the lowest of all priorities in in the sort of cross specialty prioritisation frameworks. So where are we with recovery and remobilisation? I was on a meeting yesterday with the Scottish Government, and we're almost talking now about how do we recover the recovery, because we were in a recovery phase which has now been hit, and we have to recover that recovery. Sort of 2 weeks ago, there was an NHS recovery plan published for Scotland for the next 5 years, which was ambitious. I'm assured that it doesn't involve Nicola Sturgeon doing knee replacements, but that was certainly the concern when she popped along to the Golden Jubilee Waiting Time Hospital to launch the plan. But she was at least being supervised by a robot, which was going to stop her making any significant mistakes with the cuts during the knee replacement. Under that sort of national recovery, we have to move towards an evidence-based COVID response. This is going to be with us for a while, and that will be a pressure at the front door. And I think more forms of firewall and insulation of our scheduled care work. And within Scotland, that's being driven through a plan to have more sort of treatment centres where scheduled care will be undertaken in a separate fashion. That has its own staffing and capacity and resource issues. We have to challenge a lot of the traditional assumptions about how we deliver outpatient and inpatient care. We've got to look at what actually we need for our planned admission capacity using tools such as GIRFT, and work together to share nationally our best evidence and experience. We will make mistakes along this way, but we have to be honest and frank and learn from it. We ultimately need to look after our workforce, because this workforce is what we need to look after our patients, and the workforce are reaching quite significant levels of burnout at the moment, and we do need to work with them to be able to get them through the next few months and years. So I think in conclusion, I've given a flavour of where we are with COVID in Scotland. It's not too different from England. I think perhaps with the return of schools, we've maybe foreshadowed what what might be seen if there is a degree of a takeoff in England, but I think we have to watch this space on that. We do have differences within the health service. We have a population of 6 million, which is similar to some large English regions, or perhaps London on its own. But we do have very close relationships between the orthopaedic community and the government, where we are able to feed in and influence policy. We also have an agile research and audit network, which has been able to step up and give answers to questions that have come up through COVID. And we've also been able to introduce some aspects of transformational change perhaps faster than we might historically have been able to. So yeah, thanks very much for this invite. It's been a pleasure to talk to you, and I'd welcome any questions that you have.
That's great. Thank you very much, Paul. Very comprehensive. And certainly there is differences between the different countries. But we all suffer from the same issues, I'm afraid. It is a little bit scary looking at your graphs and your return to school and what's going to happen in England, where I live. So we just have to wait and see. So just going to some of the questions, if that's okay. Val, there's lots of comments here about you and thanking you for joining us. Joe Williams, our chairman, is once again thanking you for your involvement with the NOA and sharing your story, because it's the patient stories that we can share that really influence people. Orthopedics is way down the list of priorities. As you can see, it's sometimes really difficult to make the point that our patients are really suffering badly. And it's not all about a hip replacement. It's the effects of a hip replacement, immobility, mental health, chronic pain, all of that together. And your story has been very, very powerful. So there is actually a question here. There's lots of nice comments for Val, but there is a question to Val. So you're currently on the waiting list. Just curious, have you any idea what it says is what is your priority on the list? Do you know what your priority is on the list? And have you had any contact from your trust in the last 3 months to find out how you're doing, and are you in trouble?
I don't know what my priority is. I have actually had a telephone pre-op assessment.
Okay.
And the nurse who did that said that she would call me in for obviously a face-to-face assessment, like bloods and ECGs and that kind of thing. And that assessment only lasts for 18 weeks. So I did query that. I was talking to people in admissions. They know me very well by now. And I said, look, is this feasible, 18 weeks? And they said, well, go ahead and have it, because if we get a cancellation, then you are already pre-opt and ready to go. So I'm hoping that might happen. But I'm thinking, the list now seems to be about 6 to 7 months, which for me is manageable actually, because although I do have pain, it's not that bad. I manage on paracetamol as opposed to the heavy duty stuff. My mobility is much increased. I'm able to go out and about. My concern, of course, is that the knee will deteriorate as the other one did over the months. At the moment, it's okay, but my concern is that it will deteriorate. Good. And I know that, as an orthopedic patient, we're not high on the list of priorities, because it's not, what we've got is not life-threatening. But I tell you something, it is life-changing.
Oh, that's a very good comment that we've heard on many occasions. It is life-changing, and it does affect your other health, your mental health, and other physical health. Immobility, you talked to us about your problem with your bed sore, etc., your urinary tract infection, all of these things which are associated with immobility. So it does, orthopedic problems do affect your general health, which is a very important point to make, and thanks for making that. just about contact. So you've had some contact with the hospital. They've given you an update,
Yes.
and they've kept in touch with you, which is great. And it's really,
Yes, they have. Yes.
it's really good to hear that that happening. I'll just go on to there's a question here, I think, directed towards Paul. Yeah, there's a big decrease in the use of video calls by consultants, for instance, Attend Anywhere, since the first wave. So we found that as well, that a lot of enthusiasm from the first wave when we couldn't do anything, but less enthusiasm now. How is that in Scotland? How do you encourage its use? So do you believe that video calls are better than telephone calls? There's some cynicism among some consultants as to whether it is a useful thing to do. So I'm attending a neurologist. I asked for a video call because I live nearly 100 miles away from his practice, and it was refused because I don't think video calls are useful. I do a lot of video calls, and I'm very keen on them. I think there's a video call, seeing somebody's face makes a huge difference rather than just talking to them over the phone. So how, Paul, what's the flavour in Scotland for video calls in orthopaedics?
I think it's very consultant dependent. So I see a big role for it in my practice because I've got quite a tertiary practice. So patients get referred to me from, similarly from 100 miles away down in Dumfries or in Forth Valley or even down around Mull of Kintyre, etc. And quite often they've maybe been worked up. They've already got X-rays, a CT scan, and actually physically laying hands on the patient, that doesn't really change that much. The video does help in that situation, in that you can you can certainly get more of a flavour of that sort of patient, their likes, their wants, how perhaps how bought into surgery they might be, or even just sort of, sometimes you talk about surgery and you see somebody recoil, and you can't really gauge those interactions, even on a sort of telephone. So I tend to use sort of video for that. I use telephone quite a lot for returns of patients who I know, and it's basically a sort of a checkup or giving results or something along those lines. Partly because it's a bit more, there's still a lot of technological stumbling blocks with Attend Anywhere. I think my success rate is about 50% in terms of patients making it through. There are potential issues about digital poverty, and with a video call you're relying on a patient having a data plan or broadband or some form of access, and it's very easy from us from a a middle or upper class background to think that's normal. But Glasgow Royal Infirmary, 50% of our patients are in the most deprived socioeconomic quintile in Scotland, and people don't. So a lot of people don't have data, or even traditional assumptions. People say, well, the elderly won't like it. That's not true either. There are very technologically equipped older people, and sometimes it's the younger people who you actually have trouble with. I've also had interesting consultations where somebody they've been at work, or they've had colleagues in the background, or they're in the back of a van, or they're on a building site, and so they're having a lot of new challenges in how you manage those sort of situations. I think we're probably, it's a learning experience. We're finding what works for video, what doesn't. The trouble is that, my own board plucked a number out the sky and said, we want 40% of consultations to be non-face-to-face. And, that doesn't work, because if you're seeing everybody by video or telephone, and 70% you say, look, I need you to come back and see face to face, you're wasting time, you're double handling, you're causing a problem. So I think we're probably in that that period of finding out what works for us, as a specialty, as an individual, and for our patient groups as well.
Thank you. Yeah, just another question through. It's probably for you as well, Paul. Any tips you have in introducing patient-initiated follow-up? Key areas for success in terms of clinical pathways you could share?
So probably the biggest ones have been in the area of joint replacement returns, partly where there are very good long-term evidence of good outcome, and nowadays, when in fact your problems with a particular implant or something are more likely to be picked up by registry data rather than an individual consultant following up their series. We had already sort of moved to having, in most cases, a one-off post-operative review somewhere between 6 weeks and 3 months, and thereafter it being patient-initiated if there was any problems. There is a movement to move that to a sort of virtual attendance, so telephone or video thereafter. I know that there have been discussions about, down the line, do you need X-ray review? Do you need those then reviewed in virtual clinic? Do you need to send out PROMs? Locally and in a lot of places in Scotland, we've taken a fairly sort of pragmatic approach, and it's based on a lot of internal audit that patients who were having problems didn't really come in through routine review. They came in anyway via their GP or a presentation with a problem, and so the routine review really didn't add value. You need to get your staff on board. You need to get your patients on board. You need to have a seamless process when somebody does trigger an alert, so that they don't get through to some random person who says, oh, it's been 7 months, you now need to go back to your GP. You need to have a dedicated phone line, people who are trained to get that patient into the right clinic at the right point.
Yeah, we have a system where we have an information leaflet that we actually give to patients that tells them all about patient-initiated follow-up, how to get through with the contact numbers, how it works. A little box to say you're on a patient-initiated follow-up for 3 months, 6 months, a year. So we have that process in place. In addition, for shoulder replacement follow-up, many of us used to do a 6-week X-ray, some a 6-week and a 6-month X-ray with constant and various scoring. We've got rid of that now. So if everything is okay over the telephone at 6 weeks, your next visit is at 1 year for a check X-ray. So and we audited. We did a little audit of what happens at these 3-month follow-ups. And the answer is very, very little, except a smile and a handshake and a thank you very much. So we felt justified in postponing our first real face-to-face follow-up to 1 year unless the patient shouts. We're coming towards the end. There's one other issue, Paul, that you might just comment on. So Val said she felt really, really guilty by paying up front and paying money and betraying the NHS. So for surgeons as well, there is a bit of an ethical dilemma here, where we have these patients waving cash at us saying, can you do it privately? And actually, you can actually access the private system and you can actually help these patients out. Have you any thoughts about how we stay ethical during this really difficult period?
It's slightly less of an issue in Scotland, and I think that's probably why we're lagging behind a bit on sort of recovery. So whereas there was quite a significant shift to the private sector even during the first couple of waves, we haven't had that because private is a very, very small minority. Out of my own department of 17 consultants, there's really only 2 or 3 who do private work. So there are sort of less of those conflicts. If a patient asks me, I would facilitate it. I would write to a colleague who in the private sector who does it, but I don't have that internal sort of conflict, and there hasn't really been any accessing of significant private capacity. We do have a national waiting time resource, which is the National Waiting Time Hospital, the Golden Jubilee in Glasgow, and they have an allocation for all the boards depending on sort of waiting times, and patients can be given the opportunity to sort of go there. The ethics of it are very difficult. I think I would feel, it's truly tragic that a patient has to go and access, life savings to go into the private sector. But I think if they do that, they shouldn't feel they're betraying the NHS. But they should not have to do that. I think that's what it comes down to.
Yes, I feel the same, really. Any comments, Val, on that?
I think one of the main reasons why I decided to go privately was the fact that all elective surgery had stopped and I had no idea about when I might get my operation. And again, I'm not alone in this. I'm quite typical, I think, patient in this, is that you just left. There's no idea when you might eventually get to the top of the list, or when the list might even start again. And I think that is a problem. I don't know what you can do about that.
Well, I think as much communication as possible is the answer to that. I had a personal issue about emails, and I felt it was very wise to use patients' emails and to contact patients by email. There's a lot of people like that form of communication, but it's thrown up a few issues in our trust locally, using emails and instead of lots of little bits of paper coming out in the door on a regular basis. So I think there should be and can be an improvement in our communication, I think, with patients, and we need to look at some transformational changes in how we deal with patients who will be on long waiting lists over the next few years. So that's an area I think we need to address. So I'm just going to close things down now, and a big thank you to the NOA, to Val and to Paul for sharing your stories and sharing what's happening north of the border. It's been really useful. I'm just picking up on the comments about patient-initiated follow-ups, and in Oswestry we have a system that I think is very, very well. I'm very happy to share that with, I think it was Marie Peplow, Amanda Gaston, anybody else. That I'm very happy through the NOA to share my email with you and to share that information. We've no problem with that. So if you want to contact us after the meeting, possibly through Claire Harris, that would be very useful. Hopefully we can help you out in that respect. I'm going to close things down now. I'm just going to share my screen, if that's okay, and go to my very last slide, which is here. No, sorry, now we're getting there. We're getting there. So as well as the thank yous, yeah. So the NOA annual conference is coming up in October in Birmingham. It's a face-to-face conference that we hope will work well. Claire Harris is well behind the scenes organizing things. So hopefully the NOA members that can make it will make it, and everybody's determined that it will be made extremely safe for everybody. We have our next webinar is about prioritization and harms review. Again, finding out what's happening with those patients on the waiting list and hopefully reprioritizing those patients who are in trouble. So that's in November. And then, of course, the BOA is at the end of September, and I wish the BOA every success with this conference in terms of efficacy and safety. I hope it all goes very well. And on that note, I want to thank everybody involved, everybody in the background, Fallon and Claire and Anne Hoey, everybody else involved in the webinars. And hopefully we'll see some of you perhaps in Birmingham, and hopefully we'll see others at the various webinars coming up over the next year. So thank you, everybody. I'm going to close things down. There will be a feedback thing will pop up on your screen. I'd be most grateful if you could fill that out before you leave us. And on that note, I'm just going to close things down.